Good afternoon, everyone. I'm Manuel Diaz Ramirez. I'm the Director of Community Health Action at La Clínica del Pueblo. And under this strategy at La Clínica, we implement our health literacy initiative for our Latinx communities. With me today, it's Tania Ruiz. Tania is our health promotion manager under Community Health Action, and also Ashley Cabrera, our health communication specialist, directly involved into the implementation of our health literacy initiative. So we are very happy to have the opportunity to share with you what we are learning, which is a continued learning process, on how to enhance our health literacy understanding and capacity to implement these strategies and to be a health literate organization serving the DMV area. So I'm going to start sharing my my screen. Just give me 1 second. Tania, can you see my screen?
Can you hear me?
No, now I can.
Okay. Sorry, my headphones got disconnected, but now they are working. So I didn't
Can you
listen last week.
see the presentation mode of the?
Yes, it's perfect.
Okay. So we are going to share, as I mentioned, we're going to share a little bit what we are currently learning on our health literacy approach to our communication targeting patients, clients, and participants and community members. We are going to discuss the context of the Latinx communities in the U.S., but particularly in the DMV area. We're going to share briefly how we understood the concept of health literacy and its importance and the impact on the communities we serve to enhance their understanding of the health messages that we disseminate for them and to them. And we are going to share some of our best practices on this purpose. The health literacy toolkit that we are going to share today, it's the structure of what is going to become the final version of the health literacy toolkit. As our purpose today, Tania, Ashley, and myself, is to hear from you and receive your input and feedback on what you are going to hear and see today. Then produce the final version that's going to be posted and available for everyone to use as needed. So briefly, who we are, who is La Clínica del Pueblo? For those who are not familiar with our organization, La Clínica del Pueblo has been serving the metropolitan area since 40 years ago. We are in our 40th anniversary this year, and we are now a 501c3 organization. We are a community-based organization. We are a federally qualified health center and a patient-centered medical home. We like to see ourselves as a community of care in that sense. For those who doesn't know, La Clínica was founded in 1983 by Salvadorian immigrants seeking refuge in this area from the violent civil war and natural disasters occurring in Central America back then. Health advocates in the area help these immigrants to found La Clínica del Pueblo in response to the emergent health needs of the displaced migrants due to those social issues as mentioned before. They were primarily from El Salvador, but also from Guatemala, Honduras, and Nicaragua at that time. Currently, the face of the new waves of immigrants represent um, the variety of countries from Latin America, including the Caribbean countries as well, and not only Spanish speakers. Um, for many of these immigrants, it's important to mention that accessing healthcare services in the United States was nearly impossible due to cultural, linguistic, and economic barriers they faced. Additionally, since these conflicts happened during war, asylum, and refugee status were not afforded to them as their governments were under um, regimes that didn't recognize their needs. Um, so having a sense of not legitimate refugees impacted their search for health services. Of course, trusting. I mean, the historical mistrust with the medical field also impacted the way they were looking for these services. Um, we serve mostly Latinx immigrant communities in the DMV, but we serve also other immigrant communities. Annually, through direct services, we serve around 4,500 people annually. We have two medical sites, one school-based site, and one community health center located in Mount Pleasant in DC. And what we do is summarized in our mission, which is to build a healthy Latino community through culturally appropriate health services, focusing on the most in need. So with that, I will pass it to Tania for the next segment of the presentation.
Thank you, Manuel. And just as Manuel was like explaining like a brief history of La Clinica and how it opened its doors, we really wanted to include a little bit more of information on the Latinx communities we serve and that are in the U.S. Currently. So next, sorry about the little really little text. This is not following health literacy standards, of course, but we really wanted to share this story just to show a little bit more of the context and the realities of the community and the clients we serve. So this is a story of Mr. S. I will read it out loud, so not everyone can lose their sight while trying to do so. So, Mr. S is a 55-year-old Latino man who lives in a two-bedroom apartment with relatives and supports his family by working in a grocery store. During the COVID-19 pandemic in the United States in 2020, Mr. S is an essential worker. He reports symptoms of low-grade fever, chills, cough, shortness of breath, and chest pain. When working becomes impossible due to his increasingly severe shortness of breath over 2 weeks, he visits a clinic and is diagnosed with COVID-19. He becomes lethargic as his symptoms become more acute and transferred by an ambulance to a local emergency department. His oxygen saturation now in the low 90s. Mr. S. past medical history includes type 2 diabetes, obesity, hyperlipidemia, hypertension, gastroesophageal, I'm sorry, I don't know how to say it in English, but reflux disease, obstructive sleep apnea, and vitamin D deficiency. A frontal chest radiography demonstrates bilateral multifocal airspace opacities consistent with multifocal COVID-19 pneumonia. Intensive care unit admission with intubation and close monitoring is recommended. However, Mr. S expresses worry about his inadequate insurance coverage, inability to pay an ICU stay, and inability to work. Mr. S asks to be discharged against medical advice, but eventually agrees to ICU admission for management of COVID-19 related acute respiratory distress syndrome. Mr. S is intubated for 13 days, during which his condition is complicated by COVID related cardiomyopathy, superimposed bacterial pneumonia. He's transferred from the ICU to a general medical floor on day 14. On day 16, on day 26, Mr. S is discharged to a rehab facility. When Mr. S was asked why he did not get evaluated and quarantined as soon as his symptoms started, he responded that the grocery store where he worked remained open during the COVID-19 pandemic because grocery stores were considered essential by the state and that he had no option for remote work. Mr. S' employer did not offer flexible medical leave, and Mr. S was concerned that his insurance would not adequately cover the medical costs for an emergency room visit, a potential hospitalization at an out of the network hospital. His lack of financial reserve exacerbated these concerns to pay monthly bills and support his family. Mr. S concealed his symptoms to keep working and to avoid medical debt. So that's like not the really short story about Mr. S. But what we wanted to discuss here with you, Manuel, if you can go to the next one, is taking into account like these story of Mr. S. What do you think? Um, what layers of vulnerability do you see in this story? And this is like anyone can talk. So, um, do you think like what we see with Mr. S is common in the Latino community, in the Latinx community we have in the DMV?
Yes.
Yeah. So I just wanted to include this story because this is what we see every day at La Clinica, and I'm sure like many of you see from your agencies. But basically, the Latino community lacks um, and has a lot of increased vulnerabilities because of many factors that, of course, are really complex and not just like Clinica or one agency can alleviate all of that. But this is just to show a little bit of the layers of vulnerability in the Latino community, including overrepresentation in low wage works, education gaps and language barriers, financial constraints, social factors and living conditions, and coexisting like situations that really put in a really vulnerable spot our community and the community we serve. So basically, just like to give you a little bit more of context of the Latino community that we serve, is that most of our clients, as Manuel was mentioning, they come from places such as El Salvador, Guatemala, Honduras, like this Central American triangle, and they have a TPS, which is a temporary protective status. But many of uh, even though they have like this status or like immigration status, like there are many things that they cannot apply or it's really limited. So that's like one huge barrier that we have with our community. The TPS, as I was mentioning, there's a lot of lack of ineligibility for many safety net programs, including Medicaid. Another layer of complexity that we see day by day in our communities that, for example, there are a lot of like mixed status within a family, so it is really confusing and really difficult for our clients to understand to what are they eligible or not. So this creates another layer of complexity. As we were mentioning, they are overrepresented in industry in service trades with few workplaces that offer like health benefits, and many of our clients have 2 to 3 jobs to support their families here. but also to support their families back in their countries. So as you can see, the context, the social context of the Latino community that we have in the DMV area, it is complex. Next, Manuel. And of course, this has some consequences in the health of our community. Here are just like some clear examples on like how all these limitations can affect our community. And for example, Hispanics and Latinos are the most significant racial and ethnic minority in the United States. So they basically represent nearly 20% of the US total population. But according to the CDC, compared to other racial and ethnic groups, Hispanics have higher rates of illnesses and death for specifically chronic conditions such as diabetes and hypertension. Also, Hispanics are more or have more possibilities to develop type 2 diabetes and also to develop a lot of complications because there is not like a um, the Latinos tend to not have like a regular place for them to manage their chronic diseases, so these creates a lot of complications in their lifetimes, and also less. They have less prevention opportunities for these chronic diseases. And of course, they have a really high, or we have a really high uninsured rate of insurance. So a lot of our clients do not have any insurance. So this limits, of course, the access to healthcare that they can have. So of course, this creates adding more inequities and health inequalities in the context of the Latino community. As I was mentioning, Latinos. Hello, I don't know why. Can you hear me?
Now we can.
Oh, sorry. I don't know why. I don't know if it's the internet, but I froze. But I think I'm back. Less resources, more likely to receive incomplete after or discharge instructions, and less likely to also to provide full documentation, consent, and understanding of the risks and benefits of a medical procedure. So this is just an example and a brief overview of the community we serve. So if you can go to the next one, Manuel. What do you think, like having into account like everything I just shared and what we have discussed, like what do you think we can do as a health sector to decrease these health inequities in the Latino community? And ideas are welcome. I mean, all of this like ideas and comments, like I think they are like right on the spot and much needed to our community. And it's basically like tailoring what we know to the needs, and also like culturally, linguistically, like taking all of this into account, because all of it matters. And we will discuss a little bit more like these tools in a specific and what can we do like more in detail, specifically with the Latino community. So thank you so much for all your participation and ideas. So this brings us to the next section, which is like health literacy in the Latino community. And actually, like everything you just mentioned is part of health literacy. And Manuel, if you can go to the next, thank you. So what we have learned so far at La Clinica, and this like touches right to everything that you just mentioned, is that access to information is not necessarily understanding the information. So, a lot of our community members, they know that they need to eat more fruits and vegetables. They know, like many of the information we share with them. But not necessarily having them the access to information means that they will act on it, not because they don't want, is because there are like many barriers in the environment that prevent them many times from doing so. So people in modern society are expected to actively engage in the management of their health and to make a wide range of health decisions. And these decisions basically require comprehensible health information that is accessible and appropriate to the needs and cultural and social backgrounds of the individuals. And although healthcare professionals have historically been the primary sources of health and medical information, uh, there is like an increase in the media reports and how it is super important the expansion uh, on how the information available to our community needs to make a switch and needs to have some tweaks for actually um, to be successful in what we're trying to convey to our communities. So um, next, so basically, with this project, we really gained a lot of information and knowledge in health literacy, and actually like dividing health literacy, in which there are two types of health literacy: the individual and the organizational one. And I think in past years, like a lot of emphasis has been done in the individual health literacy, which is the degree to which people can access, understand, and use information and services for health related decision making and actions for themselves and others, rather than organizational health literacy, which is the degree to which organizations equitably enable people to find and use information and services to inform health related decisions and actions for themselves and others. So I don't know if this is because we have been like really in touch with the in synchrony with the topic of health literacy, but there has been like a shift in the reasoning behind health literacy and how um, now instead of like giving all the responsibility of health literacy to the individuals, it is time for systemic changes and organizational changes for actually adapt and provide make changes to reduce the demand and burden imposed to our clients. So this is more a shift that we need to change and have systemic changes, not necessarily the individual needs to change, but the organization and the system needs to change. So that is basically like the shift we are trying to do and think about and actually promote that information internally at La Clinica. And this is just reinforcing what I just said. We know that health education and promotion and prevention messages are more likely to reach upper middle class with a high level of formal education, who are insured and who are fluent in English, leaving our populations that we know that don't fit any of those categories more likely to develop or suffer from chronic diseases like the story of Mr. S. So this is just an idea on how we need to shift and yeah, shift the individual responsibility to more an organizational and systemic one. I don't know if anyone has any thoughts on that, but please, you can interrupt me at any time. So in order to do that, organizations obviously need to adapt and make some changes. And that's why we did some research and we found the 10 health literacy attributes. And this is just an idea on how complex health literacy is. It's not only like, educational materials, like it goes beyond and touches like every single part of La Clinica, for example. So the health literacy attributes, touch on um, phone systems, touch on like the whole like signage at locations, touch of course in all the educational materials, also touch on how we speak to our community, how we communicate, how we convey messages, how we share it, like all the educational materials. So it is super complex, and it is not just about like flyers or pamphlets. It's really really it really universal and touches a lot of things um, throughout the organization, and should in any other organization. Next. So this is just a list that of the attributes. So, for example, the first attribute is about leadership, and how there should be a buy-in on the concept of health literacy within the leadership of La Clinica or any other organization, to actually adapt and include health literacy lens in the mission, structure, and operations overall of the organization. Um, how it is important to integrate like the vision of health leaders into planning, evaluation, patient safety, quality improvement. It also, for example, attribute 3 is how, okay, now that we have like this understanding, how we prepare our our workforce, our staff, how we prepare all of them to be health literate and monitor progress throughout all of this. Also includes our population, how we design, how we implement, and how we evaluate the health information and services that we provide, but also how we include like the comments or the ideas from our community. So open these spaces not only for us to do all the work, but also to work with our community to actually do the changes and receive feedback. And I can go on and go on and go on, but this is just like the list of the 10 attributes that La Clinica is basing the health literacy strategies currently. So it will be part of it is part of the health literacy toolkit. We will share the toolkit with you if you want to use it. But this has been a great like frame for us to work towards um, enhancing our health literacy approach. So as I was mentioning, La Clinica has been making like a lot of changes and enhancing like all what we have done through health literacy. So first, I'm just gonna briefly like share like our journey through health literacy. Um, this project has helped us to put like some structure, and the first like big thing we did is to actually do an assessment. So we did an assessment that basically analyzed how we were doing based on those 10 attributes that I previously shared. And that assessment was actually completed by staff members from different departments and different programs. Um, and we decided to do it like that because I was mentioning health literacy is not only one program or only like community, like facing community facing staff. It is everything and everyone, is systems, is operations, is everything. So a representation from many departments at La Clinica um, did the assessment, as well as our community health workers and community members. So we had like feedback from staff, but also from community members. And these basically what it helped us is to gave us like a baseline on how we were and what we needed to do. So it gave us like clues on where we needed to focus. Additionally, we created a health literacy committee, and as I was mentioning, we invited and like many of the departments at La Clinica are represented here. So it was really important for us to have these representation, these diverse representation, but also it allow us to get out of of our silos and actually start working together and in common goals towards health literacy. And the main idea of the committee was basically to promote a universal approach to health literacy at La Clínica. So we meet in a monthly basis and we discuss from public health campaigns to processes to everything related to health literacy in the organization. And finally, based on the assessment what we did that we did in the committee, we created a toolbox that it's basically a toolbox that has a lot of resources and has a lot of like our best practices, specifically in the Latino community, um, to share internally, but also to share with other agencies, and they can of course tailor it to their own needs. Manuel, I think, yeah. Thank you. Um, so this was just like to share our process, and now I'm just gonna share like some of the best practices we have enhanced through all this process. And basically, what we're trying to do is uh, to create this awareness that I just shared with you that responsibility is not individual. It should be, one part of course, will always be individual, but we should also enhance the organizational piece of it, of the health literacy. And a way we can do that is by implementing universal health literacy precautions. So, Manuel, if you can go to the next one. So universal health literacy precautions are basically practices or best practices that every like agency or organization needs to make uh, to stop assuming um, if a client is health literate or not. So basically, it's assuming that everyone, regardless of their backgrounds, regardless of anything, anyone can have a challenge in health literacy. It doesn't matter if you have a PhD, like you can actually have problems understanding, prescription or like instructions from your providers. So it's just assuming like this universal approach that everyone can have difficulty comprehending health information and accessing health information and services. So these precautions are aimed to simplify communication and confirming comprehension for all patients, to minimize the risk of miscommunication, making the office environment and the health environment and the healthcare system environment accessible and easy to navigate to all the clients, and of course, support patients' efforts to improve their health. So those are like the main things we want to achieve by promoting universal health literacy precautions at the clinic. We have found three main areas where we want to promote this universal health literacy approach. The first one is the area of the spoken communication, written communication, and self-management and supported systems. So those are the three main areas where we want to actually promote universal health literacy approach and provide tools to our staff on how they can achieve these or have these precautions with our community and clients and patients. So the spoken communication, this is an example on how it is super easy to have miscommunication. So this is an experience from a practice. So patients misunderstand health communication more often than clinicians may think. For example, one practice using Tool4 shared a story of a clinician who told a patient that they could not use a local treatment to heal her wound. the patient thought she was going to have to travel to another city for care instead of understanding that she could not use a topical treatment. So it is as easy as that to misunderstand and actually comprehend a totally different thing. So next. So what we want to embrace with in the area of spoken communication is basically to affirm that our client understands what we are sharing with he or she. So clear spoken communication is fundamental in the world of health literacy, and it ensures that the information is accessible and well received by patients of diverse backgrounds and literacy levels. Again, using the universal approach where you don't assume if this person is going to understand or not. For us, everyone can have a challenge understanding. So in the toolkit, we have included some resources and examples on how we can improve our spoken communication. So we're going to share the toolkit. We're trying to put that in our website so it can be like more interactive. So you will have access to all of these tools. But some of the tools we found and we have been doing at the Clinica is a teach back method. That it's basically, um, asking the client to repeat what you just told to ensure that the client understood what you just said. So there's like a way on how to do it, and the more you practice it, the more it sticks to your practice and how you deal with patients in a daily basis. Another resource we have in the toolkit is the Ask Me Three. So it's actually like putting posters in like our examination rooms, in our clinics, in our sites to ask me three questions. And it is, um, I don't remember the exact questions, but it's basically encouraging the clients that it is okay to ask and provide like this safest space that if you don't understand, it is actually my work to make sure you understand it and answer the questions you have to me. So it's creating this safety environment. Um, Also, we have included an spoken communication assessment. And this is actually something that every health educator or someone that serves clients can do it. And it's just an assessment to that answers if you have been doing or applying the teach back method or ask me three. So it has some tips for our health educators. And I don't know if you have any other examples that can be included in this area of the toolkit. I know we're running out of time, but if someone wants to share something, please. Okay. And this is a video we have. I don't know if we have time to share it because it's like 5 minutes and we have like eight. So I will send the link through the chat so you can see it. But it's a video we did to create vaccine awareness, and some of the like best practices we can share, like creating like videos and everything, audio visual materials, is that we always, of course they are in Spanish, we always include community health workers or like clients or community members, so the community members that see the video like feel represented. They see similar faces, and yeah, they feel represented with the story and like everything that has been shared. So those are like some of the best practices we have had creating audiovisual materials. And another other tips for spoken communication is never use acronyms. repeating important information, and you can do this by doing the teach back method. Give information in small chunks, articulate words, read written instructions out loud, speak slowly, and show whenever is possible the desired action. For example, for social distancing, elbow sneezing, etc. So those all of that is included in our toolkit. Then we have the area, yeah, no two acronyms. Another area is the written communication, right? And patients misunderstand health. Oh, sorry, this is a typo. So Manuel, if you can go to the next one. So written communication in healthcare refers to a wide range of written or printed materials. And a lot of the examples you shared earlier, for example, was uh, to create it was like to create forms that are in a language that our community understands. So yeah, all of that, including prescriptions, included informed consent form, discharge summaries, educational materials. So all of that written communication, it's important, and our people actually take if it is important for the care of our community. So there are many of tools and resources to actually ensure that the written communication we provide to our clients is health literate. So there is we include in our toolkit the flash king card level. So that basically what it does is that with every written material that we have, we can actually measure the grade level that it's written on. So for in order for us to create health literate materials, we need to aim to a fifth level, primary level of the material. So that tool measures that. The approach of need to know versus good to know. Sometimes we really want to provide a lot of information in our materials, but it is really important to stick just to the meat of the information and not like a lot of jargon and information that it's not needed. And checklist, we do that with our materials. So there are a lot of tools that we can use to ensure health literacy. This is a need to know example. For instance, uh, we have graphics that are similar to the community we serve. We provide information that it's just like straight to the point. We provide the information that the person needs to act on. The information is real for the person. The information allows person to identify exactly what to do and how to do it and when to do it, and actually do it. Like we also share like resources on where to get help. So this is an example on how we try to be clear in our messaging, but we try to do every time to provide, of course, information, but also have a call to action. It's like, okay, now that you know it, you need to do this, or it will be great if you do this. And if you need help, you can call us here. So this is an example of a graphic material we created around COVID. And of course, the plain language. We need to do a lot of plain language in our materials to make it easy to understand. Simplify complicated medical health language. Like someone just heard, like it's asset. You don't need to say like all of that complicated word, and uh, it needs to be culturally and linguistically appropriate. The final area we have is the self-management and supportive system. And this is basically what you just share with me. It's trying to understand the context of our clients and using that context is like, okay, what tools can we use to help our population, our community to other services and needs they have. So in order for us to do that, for example, we create action plans where health educators have like action plans with each client where they set up their goals, and it's easy for our clients to manage their progress in 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 toward their goals. Also like referrals, how you do referrals, you actually provide like a form, like all of this counts. So I think my time's up. But just to close is to let everyone know that health literacy matters and everyone has a role in it. It doesn't matter if you work at, at operations, like you have a role in health literacy. So it is a work for that it's needed from all. So that's it. I don't know if anyone has like any question or anything else. We will be sharing the actual toolkit, and thank you so much for your attention.
See that you guys beforehand, but thank you all for your participation, and we'll be following up with the slides.
All right, thank you.
Thank you, everyone. Please fill out the evaluation.
Thank you.
Everyone.
Have a good
Thanks,
one,
everyone.
everybody.
Good to see you.